I've been a registered nurse for 10 years and a stomal therapy nurse for 6 years. I'm a stomal therapy nurse at a colorectal surgery in Adelaide. I work for 8 surgeons. Previous to that, I worked 9 years in a private hospital. I'm very lucky in my setting. I would have normally said challenges is actually seeing a stomal therapy nurse preoperatively, but because I have a really good support surgeons, they actually get all their patients to see me. Even if their stoma is a possibility, they'll see me pre-op and have a really good education session. I think the non-knowledge of the patient is the biggest challenge. Their biggest fears are coming out when they come and have their chat with me. They're worried about leakage, they're worried about smells, or how they're going to continue to go to work or look after their family just because they've heard the word bag. I tend to not see them on the day that they've just seen the surgeon, because if they come straight from being told they've got cancer and they're having surgery and they're having a bag, that's not the ideal time to see me, because virtually they've heard 2 things in the doctor's office. They've heard cancer and they've heard bag. So everything I've got to say is not done on that day. I'll go down and meet them in their doctor's office and just have a bit of an introduction with them. Then we'll arrange another time for them to come back. And I always suggest that they bring back a loved one or someone that's going to be a second pair of ears, etc. for them. I don't really find that I have too many other challenges besides that knowledge base of the patient, and that's the hardest thing. So when you've got a patient coming in for their little chat, you've got to work out what their level of understanding is. Medical knowledge is not always what everyone has as well. So the hospital stay and the surgery alone is the daunting thing. Then we go on to talk about the bag. And that's a bit of a challenge for the patients. I think the main job for the patient after their surgery, when they're still in hospital, is just recovery. The bag to me is sometimes, and I say this pre-operative to my patient, the bag is secondary. Your main focus and your main job is your recovery from your major surgery. You'll eventually get the stoma nurse from the hospital to come in and show you the bag, and you'll learn how to look after it, and that's secondary. The main thing is for you just to get well. Because I don't work in the hospital setting anymore, the challenges that I see post-op is flagging the patient to come back earlier to see me. So once they discharge from hospital, they've gone really well, they've gone home with a bit of community help, they're seeing me at, sometimes week 2 or week 4. If we're getting to week 4 and this patient has actually already got some problems, they think it's normal. They think it's like, oh, I'm supposed to have red skin, oh, the bag's supposed to leak because I've got a bag. And that's simply not the case. So for me, I feel that the biggest challenge post-op is actually getting that patient that is having problems in our community to come back and actually see me earlier. They just think, oh, I've got an appointment with Amanda in a week, I'll just have to deal with it till then. Where actually that's not the case. Once they're back after the post-op phase is kind of commenced and nearly at the end of the post-op, and could be month 2 or month 3, the biggest challenge that I see once they're back into the community and living their life is diet and the challenges related to bag appliance, especially if it's not a working bag. We always talk about the perfect bag. If I get you in the perfect bag, there won't be any problems. And I always refer to, well, your shoes don't fit on my feet. So if I don't put the perfect bag that meets your stoma, then you're going to have problems. And that coming back to me or calling me on the telephone to say, hey, I've got a problem, that's another challenge that's still out there. Diet is another big one because they're unsure still. They're still following something that could have been happening in hospital, and I'm not allowed to have this, I'm not allowed to have that. And I always kind of talk to them and I said, you can kind of be a bit of everything and see what happens. It's sometimes about more of a tolerance than anything else. But if you enjoy the curry, eat the curry. You might have a bag full in an hour. You just got to be mindful of that. We've got the uses of the ConvaTec diamonds. We've got the use of the, obviously drainable for our ilio patients, but if a colostomy patient was a bit more liquidy as well, they could go into a drainable. So there's different things that we can, try and make their life still as normal as possible whilst living with this bag. Majority of my patients are temporaries. We're doing a huge amount of ultra low and low anterior resections, all with covering loop-ilostomies whilst they have their chemotherapy. They're all being reversed at 3 to 4 months. So they're kind of in and out. It's my job just to get them through those couple of months and then their reversal surgery.